Welcome all of you to this live program of the Orthopaedic Principles. Today, our guest of honor is Dr. Dalal Bubshait from Riyadh, Saudi Arabia. Dr. Bubshait is a pediatric orthopedic consultant in Saudi Arabia. She graduated from the Orthopaedic Saudi Board in 2007, followed by a pediatric orthopedic fellowship in Riyadh in 2010, and an AO fellowship in Bern, Switzerland, and yet another fellowship at the Bailey's Orthopedic Institute in Florida, United States. She's assistant professor, program director, and award manager at the Imam Abdul Rahman bin Faisal University in Saudi Arabia. She's also the past chairperson at the Department of Orthopedics in the same institution. Dr. Bubshait is an AOS IMS ambassador of Goodwill since 2017 and a member of Women in Orthopedics Worldwide, and is also the IODA Middle East representative. So today it's my great honor to introduce you to Dr. Dalal Bubshait from Saudi Arabia. Over to you, Dalal.
Thank you very much for the nice introduction. So we'll be talking about a dear topic to mine is DDH, which is Developmental Dysplasia of the Hip. Unfortunately, it's very common in the Middle East and the area that I come from. So we need to educate people because it's a common also exam topic for our residents. We'll have just a few objectives about the definition, risk factors, the associations, the examination, investigation, and basic principles of treatment. So if you can see, the DDH is where the acetabulum part of the hip joint, the acetabulum part is deficient. Previously, we thought it was congenital. The child was born with it. Now we know that it is partly congenital and mostly developmental, while the children develop this shallowness later in their life, like within the first 6 months. It varies from a simple, just shallow acetabulum to subluxation and a complete dislocation. So the risk factors, when do we suspect that we have a DDH? When the child is born with breech presentation and family history. These are the two statistically significant risk factors. The rest are the firstborn, especially if the firstborn is a female, because females have 5 times higher risk than males. Anything that causes impaction syndrome, so oligohydramnios, ligamentous laxity, a large baby. And then we have the raised swaddling, and I'll be talking in details about it in the next slides. So breech presentation alone increases the risk of DDH to 20%, and it varies from one study to another. And those breech presentation child, if they were born vaginally, then there's an increased 8% chance of having a DDH. So we encourage that the OB/GYN doctors, if they have a breech child, that they educate the mother to come to a pediatric orthopedic surgeon as soon as possible. And only with the breech presentation, it's still higher risk for boys and girls, but it is, of course, more in girls. As we said, females to males, the percentage varies from a study to another, depends on the part of the world, and it goes up to 44 to 1,000 in females. And 90% of the patients who presented to the clinic with DDH have only one risk factor, which is just being a female. Family history, so it's a strong association because anybody with a positive family history of a first degree will increase the risk by 20%. Then you will add the percentage of having like a sibling plus a parent or a first cousin with a parent. A sibling will increase that up to 4% and a first cousin around 2%. Now, swaddling, it's in a specific area of the world where they use this swaddling process. So Saudi Arabia and the GCC countries, Japan, Turkey, Norway, and the Native Americans, they do the swaddling process for kids. I don't know why. I couldn't explain it except just to restrain. And swaddling alone increases the percent up to 88%. And in one of the studies in Turkey where they stopped swaddling, they banned it for a year in 2005, and the risk of DDH decreased by 15%, which is significant. So swaddling alone is a risk factor. Generalized ligamentous laxity would increase the DDH risk factor. and the combination of factors. So if you have a breech and a female, that will increase it up to 80%, 80 in 1,000. A female and a positive family history. Breech, even in males, will increase risk of DDH. So beware of the combinations. Now, the associations, we always say that if you find a child with DDH, check for torticollis, metatarsus adductus, and spine anomalies, because they usually come in up to 10 to 15% of cases. Now, there are other causes of hip dislocations that are not called DDH, but people misleadingly say that it is a DDH or developmental dysplasia, like neurogenic hips, like cerebral palsy patients. This is a different pathway, different pathology, and different management. Paralytic kids like meningomyelocele, Larsen syndrome, which is like multiple congenital dislocations. Pathology is different, management is different. And same with arthrogryposis, where they have fibrosis in the joints, and conservative treatment will usually not work and will need surgery by the age of 9 months. So it's different pathology would cause a different management plan. Now, for examination, the common thing that we're taught about is the abnormal skin folds, where you see on the dislocated side it is deeper and just below the anal verge, and the Giliazi will show not a tibial but an anterior shortening in the femur. Now, Barlow or Ortolani, we usually try to tell residents about the techniques. So Barlow, you try to dislocate the hip, and Ortolani, you try to reduce it, but they usually use force. So I usually have this video handy just to show them that it is just a simple maneuver, and you can see the left hip, it comes out, pops out, and pops in. So that this is what's called a clunk, not a click. So a click is when you hear it while it's full range of motion, and a clunk when you can feel the movement of the pelvis coming in and out. When the child starts to walk, of course, there is the waddling gait, especially if it's bilateral, because of the abductor muscle weakness. And it's usually painless, so they're not complaining of pain. When we talk about the investigation, of course, before the age of 3 months, ossific nucleus is not apparent, so ultrasound is better. We have the static and dynamic. So dynamic is when they do the Barlow or Ortolani while the ultrasound probe is there to check, like when the child is lying on the supine position, and you can do the ultrasound while trying to dislocate the hip in and out, and you measure of course, the alpha and beta angles to be sure that this hip is, if it's deficient or not. When you see the ultrasound image, you try to make a straight line. So the ultrasound would be like the hip is in the lateral position. So this is the iliac, the straight line, the iliac bone, which is the part that is here, and the F is where the femoral head is. So this line should bisect the femoral head in the middle if we do a straight line from the ilium to the femoral head. The yellow part represents the labrum, which is the cartilaginous part where we do the beta angle, and the alpha angle is the acetabular part, acetabular bony part. So we want more alpha and less beta. And then once the child is more than 3 months of age, the ossific nucleus will start to appear. Then we do basic AP X-rays. And we do all the lines that helps us, which is the transverse Hillingerian line. We do the Perkins line, which is, so the Hillingerian line is between the triradiate cartilage on both sides, a horizontal line. The Perkins line is a vertical line perpendicular on the Hillingerian line from the edge of acetabulum. So it divides the femoral, the acetabulum into 4 quarters, and the femoral head on the normal side should be in the lower medial quadrant. And if it is anywhere else, then it is either subluxed or dislocated. We do something called the acetabular index. So the Hillingerian line with a line between the 2 edges of the femoral, of the acetabular dome. Which gives us an angle of preferably less than 25 degrees. More than 25 degrees, this is a shallow acetabulum and a sign of developmental dysplasia. So we do it on both sides. And the third line is called, the fourth line is the Shinton line, which is a curved line between the lower end of the calcar and the medial calcar to the upper part of the obturator foramen, it should be a continuous line. If there is breakage of this line, this is called a breakage of Shenton's line, which is a sign of developmental dysplasia. In older children, we have different measurements that we do. Treatment matters with the age of the patient. It is very age sensitive. As the child grows older, then the soft tissue contracture becomes stiffer. The acetabulum remodeling becomes less. So we start with the simple treatments as the child is younger and still flexible. But once contracture starts, then we have no solution but surgery. So the classic teaching is 0 to 6 months. We use the Pavlik harness, some sort of a conservative treatment where we put the hip in flexion around 90 degrees and abduction 50 degrees. And it should not, while the child, it's dynamic, it's not static. So as the child is trying to kick, the most important part is they don't flex or adduct close to midline. If they adduct to midline, it means that we need to adjust the abduction strap. If we flex more than 90 or more than 100, then we risk the femoral nerve paralysis. And if we abduct more than 50, then we risk avascular necrosis. We usually do a weekly check with ultrasound for 3 weeks. Once the pelvis is stable and reduced, then we can continue. If within 3 weeks it doesn't get stabilized, then we need to abort the Pavlik harness. If it is stabilized, we continue for 2 months or until the acetabulum is fully remodeled and with normal acetabular index. Now, if the child is older than 2 months, 6 months to 1 year, then we need something more than simple Pavlik harness. We need close reduction. So we take the patient to the operating room. The choice of arthrogram matters on your situation in the world. North American and American would prefer an arthrogram. The European are hesitant about arthrograms. The good thing about an arthrogram is it tells us about the interarticular problems of the acetabulum, and it tells us that we have a concentric reduction, and it will help us see the ossific nucleus because it's not apparent. So I'm showing you an example of a child who's with a narrow safe zone. So we do maximum abduction after reduction to adduction. And if that safe zone is more than 40 degrees, then we can proceed with the closed reduction and hip spica. But if it is narrow, it means that this hip is unstable and it needs either open reduction or to abort that. So if you see this child during OR, it's very narrow safe zone. The hip immediately dislocates after 20 degrees of adduction. And this is the arthrogram fluoroscopy, where you see that there is inverted labrum, which is the whitish part descending in the hip. And you can see that the medial pooling, so the amount of contrast between the femoral head and the acetabulum is more than 4 millimeters. There is a second constriction on the inferior part, which is the iliopsoas tendon, which causes the hourglass constriction in the femoral head and the acetabulum, which means that this hip is not reduced. And if it is irreducible, then the next thing that we do is either to do mini-op reduction or wait for the op reduction age. If that hip was stable and it's good enough to reduce it, like the next patient, let's skip to the next one. As we said, there are types of inverted labrum that you see. This is a square part and this is a pointy part. And this is an example of a patient with a good close reduction. So we see the labrum here, the flat part is everted, not inverted. And we don't see any constriction on the inferior part. And once we do the abduction view, it shows that the medial pooling is around 3 millimeters and the labrum is flat and it's everted outward. So that's a good close reduction. For this patient, this is the everted acetabulum, that's the medial pooling part. So post-operative, it's difficult to check if this hip, if you can see this hip looks like this way. So we know that it is in, but if we're not sure that it is posterior. If it's posterior, it will give the same view because we don't have a three-dimensional view. So we prefer to do a CT cut. We don't do the 3D, that was just an incident. Just to see that the femoral head is not subluxing on the posterior part. So we do an axial view, axial cut, to make sure that the closed reduction is successful. We do that almost immediately. And the protocol of the spica is 6 weeks, 6 weeks spica, then another 6 weeks of broomstick, because we need time for that acetabulum to remodel. There is the Miyake classification of the types of labrum. This is mainly for research rather than something for the resident to remember. Once the child is older than 12 months, so 12 months to 1 year, then closed reduction will usually not give a good result because of the contracted soft tissue, like the ones that are mentioned here. So we need to do an open reduction. When we do open reduction, the extracapsular structures that need to be released are the adductor muscle and the iliopsoas muscle. We have the inferior medial part of the capsule that is constricted, and the lax superior lateral part that needs some sort of capsulorrhaphy. We have the false acetabulum extracapsular that needs to be inverted in. The intracapsular structures are the pulvinar ligamentum teres, transverse acetabular ligament, the inverted labrum that needs to be everted before a closure, and the shallow acetabulum itself. So 1 year to 1.5 years, we expect that 80 to 85% of the kids will remodel and fix their acetabulum. There is still a 20%, 15 to 20% chance that they need a secondary pelvic osteotomy. Now, after 18 months, the open reduction is definitive, but we'll need a pelvic osteotomy to cover the acetabulum because the remodeling capacity of the child starts to decrease. So, acetabulum. More than 2 years, we will need femoral shortening, or it depends on the telescoping in the OR. So telescoping that we're talking about is after you reduce the dislocated hip, we put our finger between the femoral head and the acetabulum, and it should go up to the medial part. If we could do that up to the medial part, then it's a positive telescoping, then the child can go without femoral shortening. If it is tight or if it's irreducible, then femoral shortening is needed. The second issue is when everybody is discussing pelvic osteotomy is what type of pelvic osteotomy. So we have the classic types, the redirectional, reshaping, salvage, complete and incomplete. So I have my pelvis. So when we talk about a complete osteotomy, the common or the classic one is where you do an osteotomy and you have a free mobile part. These are complete osteotomies. The incomplete osteotomy, when there is a part of the acetabulum that is still connected and it is not, it is stable and it doesn't need fixation. I have this small, I'll reduce this for a second. So this is a small schedule that would help you decide what type of pelvic osteotomy to use. So you have the columns that gives you, when you take history, physical examination, if you go through these lines, then it's easier for you to decide. So the first lines, the first two, the Salter, Pemberton, and Dega, are the ones when the child is still growing with open triradiate cartilage. Once the triradiate cartilage is closed, then you talk about the double, triple, Gans, shelf, or Chiari osteotomies. So the first line is the age of the patient. So once you get older than 8, then you can do the osteotomies from the third line down. The second line is where the coverage is. So we're talking about where the deficiency is. So if your deficiency is it anterolateral or is it global deficiency? So a Salter osteotomy can cover only the anterolateral deficiency. And when you need to cover the posterior part, then you need the Pemberton osteotomy. Now, the degree of correction, the third column, is the acetabular index of the patient minus 25, which is the ideal acetabular index. So if you get an acetabular index of around 45 degrees and you need to correct it to 25, then you need to correct 20 degrees. Salter osteotomy can barely correct up to 15 degrees. So if you have that child, then a Pemberton or a Dega osteotomy would be preferable. And then the hinge of the patient will help us. So what we mean by the hinge of the osteotomy is that. So this is a Salter osteotomy on the medial side. And when we move the distal part to anterior lateral for the coverage, you can see first that it uncovers the posterior column and it's hinging on the symphysis pubis. So if you do the osteotomy on both sides, you cannot do it bilateral because you will lose your hinge on the symphysis pubis. And you will end up with like a fixed flexion deformity or an inlet view of the acetabulum. So if you have a bilateral case, you cannot hinge on the symphysis. Then you have to do a Pemberton or Dega osteotomy. For the contraindications, as we said, Salter uncovers the posterior column, so it's not good for neurogenic hips. And the Pemberton and Dega osteotomy, because they are acetabuloplasty and they will decrease the volume of the acetabulum, then when the child is having a coxa magna, it's not a good option. Double and triple osteotomies are a simple Salter osteotomy, then you cut superior pubic ramus for the double and the ischial part for the triple, and then you have a free segment that you can cover more with. The Gans osteotomy, it has a difficult technique where you cut and you keep it still connected, and it's cutting around the acetabulum, again creating a semi-free segment that helps you to move. A shelf and Chiari are salvage procedure that we'll talk about usually with a Pemberton or a child with other problems. So I'll just give you small differences between Degas and the Pemberton, because that's a common issue that everybody is confused about. So they both have the same indications. They have the same prerequisites, 18 months and older, open triradiate, and you have to do a congruent hip, so you have to do a open reduction prior to that. And they have the same contraindication of a coxa magna and a closed triradiate cartilage. They have almost similar exposure. They are both incomplete osteotomies. So they have the anterior part or the posterior column still intact. So these are the differences now between both. So you can see this is a Pemberton osteotomy where I need to use this just to check that I'm doing something right. Yeah. So a Dega osteotomy is when it comes from just below, it's periacetabulum, so it's around the acetabulum. It's below the inferior pubic ramus. You go around until the middle part of the posterior column, and you cut on the medial and the lateral side. Then you put the graft that usually we either take from the iliac crest here, or we use artificial bone graft, and then we put the graft anteriorly from the anterior part. For Dega osteotomy, you can see the line on the lateral side is similar on both sides, but it goes in without cutting the medial border of the acetabulum. And the graft is usually put on the lateral side, and you can use it either anterolateral, lateral, or posterior if you want more coverage. For a San Diego osteotomy, it is also similar, where you have the cut. It's similar to a Dega osteotomy, but on the posterior column, it cuts it completely, but we don't cut the medial part of the acetabulum. So it's cutting periacetabulum, and it goes straight line to the posterior column. And again, the graft, you can use it anywhere, but we use it more for neuromuscular kids because we can push the graft posteriorly, and it gives us a good posterior column coverage. One of the complications that we get is a vascular necrosis of the femoral head. And that goes with the Kalamchi classification, Allen-Kalamchi classification, that first type is just irregular physis that gives you end up with a coxa magna. Second type is when you have a lateral bar that gives you a coxa vulga. Type 3 is medial bar that gives you a coxa vara. And the fourth type is where the whole ossific nucleus is affected, and it gives you a coxa vara, plana, and overgrowth of greater trochanter. The most important part is to choose right, know your techniques properly, because we don't want to end up with similar case where she had a bilateral Salter. The K-wires are in the hip joint, and the patient was dislocated, and she presented to us with even worse situation. A DDH, if it's done right the first time, then it's done right forever. Common complications are, as we said, redislocation if you don't do a proper osteotomy for the patient, residual dysplasia if you don't correct the acetabular index properly, lateralization if you don't do a proper soft tissue releases, stiffness of the hip and impingement if you overcorrect the acetabulum, early osteoarthritis, if they end up even without any treatment. That's a common question for everyone, is what is the highest age that you would do surgery for? So if it is bilateral, all around the world, there is almost an acceptance of 5 years for bilateral, and unilateral we go a bit higher because it's only one side. We go up to 7 years because they have up to 70% risk of complications, stiffness, redislocation, and avascular necrosis. And that's my presentation.
Thank you, Dalal, for this comprehensive talk. I mean, you've covered the entire spectrum of DDH.
Hopefully.
Yeah, of course. Dalal, a few questions. Now, Dalal, the biggest challenge is when you have a neonate, right? A very small kid. And at one point of time, we used to talk about the double diaper, or just to keep the hip abducted. There was Frenchka pillow. We have learned about the von Rosen splint. Because one of the reasons I'm asking you this is because in different parts of the world, they may not be able to make a good Pavlik harness, right? The orthotists may not be aware how to design a very good Pavlik harness. So in young kids, even premature kids, if you've diagnosed a DDH, do you think those are simple alternatives than a Pavlik harness?
The problem with the double diapers is that the second diaper, even if it's a bigger size, while the child is moving, it collapses. So it doesn't work like an abduction brace. There is a saying that when I was talking about race, that it is almost 0% in Africa. So if you know swaddling in let's say the mentioned countries, but in Africa, they keep the kids on their back with the hip flexed and abducted most of the time, or they carry it on the side where the child is like a kangaroo. So that position is more helpful than a double diaper. Pavlik harness, if you can't like buy it or purchase it, the von Rosen splint still works. It's just stopped being manufactured for a reason or the other. But if you still have that in that part of the world, von Rosen will help the hip get flexed and abducted. The good thing about the Pavlik that it is dynamic. The von Rosen, I was one of the people who were taught on von Rosen, so I saw that. It's more static than dynamic. So that's why if you can, then you can fashion it. Let's say if you can create one that helps the hip get flexed and abducted. But double diapers, unfortunately, doesn't work.
Thank you, Dalal. And Dalal, would you mind showing those osteotomies? I mean, in the presentation, we could see only a very small part of you, but now we have a magnified view. And if you can, because everyone, I mean, all the residents are really confused with where does the cut go, where is the hinge?
That's why I made this. So let's start with the classic cut. So the classic cut is here. So you go from inferior superior iliac spine, go straight to the sciatic notch, complete cut, and then For the Salter, we have a big reduction clamp usually that helps us to pull that part, the free part, anterior and lateral. So if you can see, if you do that, then this is not stable enough. I'm holding it with all of my fingers. We put the graft in between,
Okay.
and then we have to fix it with K-wires that goes from here to the medial part.
Okay, great.
So that's a Salter osteotomy.
So it starts from the anterior superior leg spine and goes to
Between
the
anterior superior and anterior inferior, around the acetabulum, and goes straight to the sciatic notch.
Okay, great.
Then we take a big reduction clamp that goes this way, and then we pull the distal part anterior and lateral. That's why we say that the hinge is on the symphysis pubis here.
Okay, thank you.
Okay, and that's a complete osteotomy that you can see it's unstable and it needs to be fixed. For a Chiari osteotomy, it's pretty much the same osteotomy, but we medialize the distal fragment. So it goes on the medial side. So it's pretty much the same small technical of the direction of the cut between a Salter and a Chiari, but they do the same. So in a Salter, anterolateral, Chiari medialization, where the whole center shifts. So the arthroplasty people, they hate us when we do Chiari for kids, because when they end up with a total hip replacement, that changes the center of acetabulum, and it doesn't give them a good coverage. So they usually hate us, and I haven't done a Chiari in a very long time. Now, these two are my favorites because we have problem with understanding them. So both of them are incomplete, where you can see in the Dega, there is the posterior column is intact. This is a Pemberton. And in a Dega osteotomy, the whole medial part is still intact. We don't cut. So on the lateral end, if you can see, they have this similar cut, which is periacetabular. It's around the acetabulum. The Dega, so for a Dega, we take an osteotome. I'll use the K-wire as example. So we go with an osteotome, and then we go to the inside. We cut round cuts until the triradiate cartilage, the ischial and the iliac part. And that's where we put a lamina spreader, and then we put the graft on the lateral side here.
Okay.
So,
and what is the source of the graft?
So the graft is from the anterior iliac spine.
Okay.
Or you can use an artificial allograft that you can fashion up to the shape that you want.
Okay. And the Pemberton, would you mind showing the Pemberton once again?
Yeah. So for a Pemberton, on the lateral side is the same cut. It's periacetabulum. But for a Pemberton, we open the lateral and the medial plates. And then when we cut medial and lateral side. So the medial part of the iliac bone is cut, and the lateral part is also cut. But the posterior column is still intact. So the hinge is on the triradiate cartilage, but the ischial part.
Okay, great.
So that's where it hinges. So we put the lamina spreader anterior, and then we open it, and it covers on the lateral side. It opens pretty much like a Salter.
And it is below the anterior inferior leg spine?
Yes, both of them are at the same level.
Okay.
Just around the acetabulum.
Okay, below the anterior inferior.
Anterior inferior, yes, just around the acetabulum. We keep just a small shelf-like part that doesn't go intra-articular. And when you put the bone graft in a Pemberton, so you put it on the anterior part, from the anterior, and then you push it posterior as much as you want.
Okay.
To give you that coverage and the hemostasis, and it helps. So there is a big recoil when you try to open. It tries to close immediately. So when you put the graft, it's a scaffold that stabilizes that osteotomy. So you don't need to fix it.
So both are incomplete, right? And you're relying on the plastic deformation that you cause it temporarily. Am I right?
Like a green stick fracture, yes. We're causing like a green stick fracture on either the medial. I lost my pointer, sorry. Either. So in the Dega, we're hinging here. We're opening on the lateral side, and in the Pemberton, we're hinging on the posterior column.
Great.
Because we're opening both sides.
And the other one is the shelf, right? A shelf acetabulum.
No, this was a San Diego.
Sandy.
So a San Diego is the Pemberton with cut of the posterior column. In the Pemberton, we stop. Sorry, in a Dega. In a Dega, you can see the posterior column here. It's rounded. I'll remove the graft.
Mhm.
It's rounded here,
Great. Appreciate.
and this is cutting the posterior column here.
Mhm. Okay, no,
So
this is
that's
no, this one is not very clear. This one, the bigger one is not clear. Yeah,
this one.
yeah.
So when you cut the posterior column here,
Okay, okay,
it's all the way through. For a
okay.
day gap, we go and half the posterior
So
column.
this is San Diego.
This is San Diego.
Okay.
We use it more for cerebral palsy because we can add the graft here so that it covers the posterior column, because they usually have deficiency here in the posterior column.
Okay.
Again,
And-
so not opening the medial side has less bleeding, less blood transfusion, and a CP will usually do a femoral part. So it helps also with decreased bleeding time.
And what about the shelf? The shelf acetabuloplasty,
So,
right?
okay.
Am I right?
So a shelf,
Shelf acetabuloplasty, it's called. Am I right?
yep. So
Staheli.
a shelf,
Staheli, known
I'm
after.
just looking. The Staheli, or there are 3 types of shelf osteotomies. So what we do with the shelf osteotomy, it's an incomplete osteotomy. So this is more similar. So we go periacetabular. We don't open anything. We just do a half cut to the acetabulum. And then the graft, instead of putting the graft that goes and then nothing is on the lateral edge, we put the graft transversely. Some sort like this.
Okay, it's kind of you're making a roof, new roof.
It's a shelf. I call it IKEA shelf. So it's a shelf. We usually decorticate this part of the iliac bone, and then we add a bone graft so that we can increase the width from this side.
Great.
So some people would cut the graft into 2 pieces and they'll make it like this, and they will fill graft in between both sides. Or you can depend on the abductor muscles to hold your bone graft together. So it's a cut on around the acetabulum, but when you put a graft, you have to increase that edge. So it's called labral support. When you need to support the labrum, like when you have a coxa magna and a child with a Perthes disease, for example, when they have a coxa magna and you just want to cover that, it's not that they have a shallow acetabulum, it's that they have a large femoral head that might cause a labral tear.
Thank you, Dalal. Dalal, thank you for this beautiful, demonstration of the osteotomy. We have all learned Salter, Chiari, Diga, Pemberton, but sometimes it's very difficult to recollect, right? Or recapitulate.
Models,
This is
3D models, yes.
Thank you.
So we
yeah,
like to do, so the American Academy does a pelvic osteotomy course.
Great.
And that can help people, and we can get the models and go, if me to come, I can do that osteotomy. And it's a good training when you have sow bones.
Great.
Then you'll never forget the osteotomy.
Thank you, Dalal. Dalal, I think that's all the questions that we have for this session. Thank you for this wonderful presentation and awesome demonstration. And we really look forward to host you again in future. Thank you so much for joining.
Thank you very much for giving me this opportunity.
Bye.
Have a great day. Bye-bye.